Good morning, everybody. Up next, we have the honor of having Dr. Jean-Baptiste Lepichon with us, giving us the topic of neurogenomics in children with epilepsy. Dr. Jean-Baptiste Lepichon joins us from the Children's Mercy Hospital of Kansas City. He is the director of the Child Neurology Residency Program. He's also the program director of neuroscience research and also the professor of pediatrics of the University of Missouri and the Kansas City School of Medicine. Doctor, we are honored to have you, and we are expectant of what we will learn from you today.
Good morning. I'm Dr. Lepichon, and it is a pleasure to give you this talk on the genetics of epilepsy. I apologize for not giving the talk in Spanish. I would have done fine in French, but unfortunately, I don't speak Spanish. So I apologize for this. So I'm a child neurologist at Children's Mercy Hospital, and I have a special interest in genomics. And so epilepsy, sort of as this slide illustrates, which is a slide from the Epilepsy Foundation, has many different causes. It can be caused by structural abnormalities. It can be caused by vascular malformation. It can be caused by tumors. But there are also many genetic causes. So the point of this slide is to illustrate the fact that there are many causes for epilepsy, but an important part of those causes is the genetic epilepsy, which likely represent at least 50% of the epilepsies that we see. And this is what we're going to talk about today. And so very briefly, over the last 15 or so years while I've been at this, doing this child neurology, really the field has exploded with the introduction of next generation sequencing. And this next generation sequencing method has introduced multiple ways to look at genes. And so these microarray, which are microchips, allow us to look at microdeletions and microduplications. And by the way, this is a topic that will come back from my talk tomorrow when I talk about congenital hypotonia. So, you know, several hundred to several thousand base pairs, deletions and duplications. And then with the next generation sequencing, we can now do exomes, genomes, and single gene panels that allow us to look very rapidly at the entire genome. So here at Children's Mercy, we were one of the places who pioneered the sequencing of the entire genome in less than 24 hours. And we have our own genome center that is dedicated to our hospital. So that has been a huge benefit. So you know, it used to be that we would think about this was our old approach to inborn errors of metabolism. And you will see that tomorrow I will show you an old approach to congenital hypotonia that will be somewhat similar. If you look at this old approach, we would see a child with a possible inborn error of metabolism, and then we'd have these sort of 3 tiers of testing that we do. The initial workup would include all of these tests, including an MRI, an EEG, and a number of metabolic studies. And then we would consider, well, maybe targeted gene panel. And then we would move on to tier 2, which included cerebrospinal fluid and other studies. And then if there was no answer, we would consider whole genome sequencing or whole exome sequencing. The difference, of course, between whole genome and whole exome being that the whole exome, you're sequencing all 22,000 genes, which represents about 1.5% of the total genome, which is 3 billion base pairs. What you're going to hear through this conversation is we're shifting this paradigm. We are really now approaching many of these with doing these studies for whole exome and whole genome sequencing much sooner. And so the topic of this presentation, and it'll be the same topic tomorrow, but for a completely different child presentation, which will be congenital hypotonia, is to illustrate the importance of this genetic testing and why introduce it sooner. So genetic epilepsy, some general concepts. So about 10, 15 years ago, we had a total of 10 to 20 genes that accounted for all of the epilepsy. So if you look at this chart right here, this is time versus the number of known epilepsy genes. So in 1993, we were maybe 1 or 2. By the early 2000s, we had 10 or 15 genes that accounted for some of the epilepsies. And in 2017, this chart reported about 85. In fact, I checked on October 26, the Epilepsy Genetic Association database, EpiGAD, reported 368 different variants for epilepsy. So it's evident that genetics is becoming an essential part of the evaluation of pediatric epilepsy. Now, some other fundamental concepts that need to be understood, and this one was a surprise to me. So if we look at all of the epilepsy genes that are known now, about a quarter of these, so this 10% is for the ligand-gated ion channel, and this 17% is for the voltage-gated ion channel. So a quarter of these are variants or mutations, if you will, in channels. And I would have expected that 90% of these would actually be in channels, and that actually turned out to be wrong. In fact, other epilepsy genes account for 3/4 of all of the epilepsies, almost 3/4. And those include structural epilepsies, and we're going to talk about a little bit about all of these different epilepsies. So the type of abnormalities that can happen, there can be microdeletions and duplications. These are actually the most common risk factor for generalized epilepsies, especially the 15q13.3, the 15q11.2, and the 16p13.11, and there are many others. So these are areas in the chromosome that are surrounded by these breakage points, and that are very susceptible to being either deleted or duplicated. And with the advent of the microarray, we found a lot of these abnormalities. Single gene mutations are also important, and we're going to spend most of today's talk talking about single gene mutation. And I just told you that about a quarter of them are the channelopathies, and 3/4 of them are structural and metabolic epilepsies. And then we'll have a brief talk about epigenetic epilepsies. So, what is the purpose of doing this? Why bother about knowing the gene? Well, because we know now that if we know the gene that is associated with the epilepsy, and we understand the protein that is associated with that gene, we can then target the treatment. And so some example of these are, for example, the sodium channelopathies. I'm sure that many of you will be familiar with the GEFS plus and the Dravet syndrome, where you absolutely need to avoid the sodium channel blockers, medications like oxcarbazepine or carbamazepine or phenytoin. That can be a significant problem in the sodium channelopathies. The mTOR-associated epilepsy, so those are all of the epilepsies that are associated with tuberous sclerosis, and those respond very nicely to mTOR inhibitors. So some of you may be using everolimus in tuberous sclerosis, and you may know that it was initially approved for giant cell astrocytomas. In fact, it has shown to work very, very well for decreasing the burden of seizure in children with epilepsy in tuberous sclerosis. Another example that is an old example, we've known about this for a very long time, and that is the childhood absence epilepsies. We know that these are caused by T-type calcium channels, and so we use a T-type calcium channel blocker, ethosuximide. And then, of course, there's gene therapy, and we'll have a very brief introduction to gene therapy at the end of this talk. So what are some other examples of what I call actionable epilepsies, what I and many other people call actionable epilepsies? So actionable epilepsies mean an epilepsy where there is something constructive or some compound that you can use to improve the epilepsy. So one example of an actionable epilepsy is the pyridoxine-dependent epilepsies that are caused by variants in this ALDH7A1 gene. And these pyridoxine-dependent epilepsies respond very nicely to pyridoxine supplementation. So you have to use pretty high doses of pyridoxine, but you will see if you do a pyridoxine challenge in the neonatal intensive care unit, you will see the EEG magically normalize in front of you. It's something that you never forget if it's happened to you at least once. The glucose transporter deficiencies that are, among others, coded by the SLC2A1 gene respond very nicely to the ketogenic diet, and these children will have marked improvements. So if you can identify that in the NICU, you can start them very rapidly on the ketogenic diet. And in fact, I'm going to use this as a parenthesis. We actually showed at Children's Mercy that you can do the ketogenic diet while maintaining the children breastfed. For those of you who are interested, I can certainly refer you to that paper. But the ketogenic diet is not does not prevent breastfeeding, which is, in my opinion, something important. Tuberous sclerosis, of course, we've talked about. You know that infantile spasms in tuberous sclerosis, TSC1 and TSC2, respond the best to vigabatrin. Everolimus, we just talked about the fact that it improves the seizure burden. In the cerebral creatine deficiency syndromes that are caused by the GAMT gene, you do creatine and ornithine supplementation and arginine restriction, and there is a much better seizure control and developmental outcome. And then in the cerebral folate transporter deficiency, you would supplement them, of course, with folinic acid. So there are a number of actionable epilepsies. So I've given you some examples where, this genetic, being able to identify the genetic cause of the epilepsy is actually important. Now, before we move forward, in order to understand this field at all, it's important to understand a few terms. Without understanding these terms, the field becomes incredibly confusing and difficult to understand. So the concept of phenotypic heterogeneity, this basically means that a single gene will give rise to multiple different phenotypes. So mutations within a single gene will give rise to multiple different phenotypes. So one example would be the sodium channelopathies, the SCN1A, which could give rise to a generalized epilepsy with febrile seizure plus syndrome, that are just children who are going to have complex febrile seizures between birth and the age of about approximately 5 years old. They'll have 6, 10, 12 complex. So every time they get the slightest fever, they will have a seizure. But then by the time they're 5 or 6 years old, they outgrow it, and that's the end of it. So relatively benign. The relatively is in quote here. And then at the other end of the spectrum, you have Dravet syndrome, which is an incredibly severe epilepsy. It's an epileptic encephalopathy, in fact. And both of these are caused by mutation in the SCN1A gene. The second concept is the concept of genetic heterogeneity. This is a concept whereas a single phenotype can arise as a result of different genes being mutated. And probably the prototypic example of that would be autism, but closer to us in the field of neurology would be Rett syndrome, that can be caused by MECP2 and CDKL5. And then finally, the last concept that you need to grab onto is the concept of pleiotropy, where a single gene will affect multiple different organs. So the classic example of that would be tuberous sclerosis, where TSC1 and TSC2 affect multiple organs. They'll affect the brain, they'll affect the heart, they will affect the kidneys, they will affect the lung in young ladies. So that's the concept of pleiotropy. So this is very important concept that we're going to come back to. So for the rest of this talk, we're going to start by talking about these voltage and ligand-gated ion channels, because they're those that we understand the best. We will briefly discuss the neuronal migration disorders. We'll have a very brief talk about an example of an epigenetic disorder, and then we'll conclude with a word about gene therapy and the future. So ion channel and genetic epilepsies. One could almost say that if there is an ion channel, it can give rise to an epilepsy. And these are some of the ion channels that have been shown to be associated with various epilepsies. So the sodium channelopathies, the best known of those are the SCN1As. The potassium channelopathies, KCNQ2 is the one we're going to talk about the most today. The calcium channelopathies, this is going to be a beautiful example of phenotypic pleiotropy. And then the ligand-gated ion channel. We won't talk about the glutamate receptors, but there is at least one epilepsy syndrome that's associated with it, the GABA A receptors, and then we'll have a brief presentation of the nicotinic acetylcholine receptors and their association with epilepsy. So SCN1A, this is the sodium channel. This is probably the most important channelopathy that you should all be aware of. And again, this illustrates the concept of phenotypic pleiotropy. So these mutations, and it makes sense if you can think about it, they occur along a continuum from, if you will, the mild to the most severe syndrome. So the mild syndrome, this would be the generalized epilepsy with febrile seizure plus syndrome, which we just discussed, where the children will start having seizures with slight fevers, and they're usually complex febrile seizures around the age of 6 months, and then they'll go on having seizures until they're approximately 5 or 6 years old, and then those seizures will remit. To the very severe epileptic encephalopathy of infancy, which is Dravet syndrome, which presents around 6 months of age with initially complex febrile seizure. Then the children develop seizures without fevers. They then develop developmental regression, and they go on to have an epilepsy that is incredibly difficult to manage. So in this type of epilepsy, obviously, you should avoid sodium channel blockers, lamotrigine, carbamazepine, oxcarbazepine. They respond very nicely to clobazam, stiripentol, and cannabidiol. So you now know that there is a form of cannabidiol that is FDA approved in the United States. It is Epidiolex in the United States. I'm not sure what brand name it's sold under in Mexico, but it has proven to work very, very nicely. In fact, one of the little girl who really was at the basis of the fad in the United States of using hemp oil, her name was Charlotte, and they derived Charlotte's Web, which is a type of hemp oil that is the type of hemp oil that was used for her, and that's where that comes from. The GEFS Plus, of course, is a self-limited epilepsy, so that's on the mild end of the spectrum, and the Dravet syndrome on the severe end of the spectrum, all caused by sodium channels. So the KCNQ2 and Q3s, these again illustrate the fundamental concept of phenotypic pleiotropy. So these are slow, non-inactivating potassium currents that maintain the cell hyperpolarized. So they're always on. The potassium flows out of the cell, which allows the cell to remain at a hyperpolarized potential. These associate with benign familial neonatal epilepsy, what we used to call the fifth-day fits. Some of you may know it as fifth-day fits. These are autosomal dominant disorders. They resolve typically by 4 months of age. In the first 5 or 7 days of life, they will start having these seizures. There's no cognitive impairment, although there is an increased risk of lifetime seizures. And at the other end of the spectrum, there's a neonatal epileptic encephalopathy caused by mutation in the same gene, KCNQ2. And so this is a neonatal epileptic encephalopathy that presents with a birth suppression pattern, which is, of course, a catastrophic pattern in infants, and is associated, interestingly enough, is associated with both gain and loss of function in the protein. In other words, in this case, it is not obvious what we should do, whether we should use potassium channel blockers or not. And this, again, is sorted out by knowing what the mutation is. So one example I'm going to show you here is all of these stars in this KCNQ2 channel. So these are the transmembrane domain. So this would be the channel pore right here. And you see the white stars, those all represent mutations that have been associated with this early epileptic encephalopathy from this paper published by John Millichap in 2012. And it sort of makes, yes? Oh, thank you. Yes, so thank you for the reminder. So it sort of makes sense that, mutations that would happen in the channel pore would cause a significant problem. And so for those, in this case, you have this R site, which is the site where the reticabine and ezogabine, which are potassium channel blockers, bind. And so those would make a very good choice to treat these type of epilepsy. So we're running out of time, so I'm going to go a little bit faster over this. The CACNA1A is another example, a beautiful example of a phenotypic heterozygosity, where the spinocerebellar, this mutation in this single channel. So, for example, the blue dots here represent the patients with episodic ataxia type 2. The white dot represent patients with familial hemiplegic migraine type 1. And the red dot represent catastrophic intractable epilepsies. So the mutations in the same channel can give rise to familial hemiplegic migraine, spinocerebellar ataxia, episodic ataxia, paroxysmal tonic upgaze of infancy, idiopathic generalized epilepsy, and early epileptic encephalopathy. And I'm going to skip this. The genetic and the structural epilepsies, of course, represent a large group of epilepsies. So, for example, the lissencephalies that are coded by LIS1, DCX, the double cortex gene, and the ARX, REL1, POMT1, et cetera, the fukutin gene, the large gene, those all associate with intractable epilepsy. And, of course, in tuberous sclerosis, TSC1 and TSC2. Epigenetic mechanisms are also important. So what are epigenetics? Epigenetics are changes that occur in the DNA that are not driven by base pair changes in the DNA. And so what can those be? Well, the DNA needs a lot of things in order to be correctly translated and transcribed. And one of those is methylation. So these methyl groups are going to drive whether a specific gene is transcribed or not. Another one is the way that they bind to the histones, these big protein complexes that allow the chromatin to be either unwound or rewound into a tight chromosome, and that will determine whether or not you can do transcription or not. So DNA methylation and histone modification are two forms of epigenetic mechanisms. So one example of an epigenetic mechanism is Angelman syndrome, which is probably the one that everybody is familiar with. So when there is a maternal deletion of 15q11-13, this results in Angelman syndrome. Now, this is, of course, an example of imprinting. So if it happened in the father, it would be Prader-Willi. This is caused by the absence of the gene is UBE3A, and this gene is methylated. And when the proper methylation is not there, you develop it in the mother, you develop Angelman syndrome. When it's not there in the father, you develop Prader-Willi. And Angelman syndrome is associated with a severe epilepsy that is sensitive to benzodiazepines. So those patients who present with Angelman syndrome, I always start them on a benzodiazepine. This is the only group of patients I would treat with a benzodiazepine as first line. So where does that leave us? I'm sorry, this was a really quick flight over the genetics of epilepsy, but where does that leave us? Well, we should say a few words about gene therapy, the future of genetic epilepsies. Is it gene therapy? And I fundamentally believe that it is. So the basic gene therapy that you're probably all familiar with relies on modified viral vectors. So these either integrate the DNA in the genome or they insert a small plasmid in the cell. So for example, you may be familiar with Zolgensma, with SMA, that inserts a small modified adenovirus 9 vector. And this is a little plasmid that is inserted in the cells, and they start producing the survival motor neuron gene 1, and it is a cure. It's a very expensive cure because a single injection in the United States, I think these days they're charging on the order of $2 million. But it is a cure. You only need one injection. It's an IV injection, so it's really easy. Other diseases that are treated with gene therapy include Duchenne muscular dystrophy and Pompe's disease. All of these diseases, and probably there's going to be a lot more coming out in the next few in the next few couple of years. And why? This is the second reason. So you may be familiar with the Chemistry Nobel Prize of 2020 that was given to Jennifer Doudna and Emmanuel Charpentier. This is the CRISPR-Cas9 gene editing. So there has been 41 clinical trials as of 2020, so as of this year, including HIV, hemophilia, mucopolysaccharidosis, thalassemia, sickle cell anemia, AML, ALL, lung cancer, and prostate cancer. So this is a technique, and the basic principle here was the, Emmanuel Charpentier and Jennifer Doudna were geniuses, is they discovered this process that occurs in bacteria, where bacteria are infected by viruses. And the virus, of course, injects its DNA into the cell, and the DNA is then replicated, and it eventually kills the cell, and it goes and makes more virus. So the DNA basically hijacks the mechanism, the DNA producing and protein producing mechanism of the cell. Now, what the bacteria have done is they integrated small pieces of this viral DNA in these CRISPR sequences in their own DNA. And when they get re-exposed to this virus, they recognize it, and they produce this CRISPR RNA. And this CRISPR RNA then binds with this Cas9 protein, and the Cas9 protein then recognizes the viral DNA and cuts it, and basically makes it unavailable. Now, where Doudna and Charpentier were geniuses is they recognized that, well, wait a minute, if we replace this piece of viral DNA by the DNA we're interested in, we can now direct this mechanism to go anywhere in a living human cell and change that actual DNA and replace it with whatever we want. So this is an incredibly powerful system that allows you to do multiple repairs at the same time, that allows you to insert new pieces, take out bad genes. So it has an enormous potential, and I think it's going to become the future of where we are. Now, is this all good? No, there's obviously a very bad potential, and this scientist in China in 2018, there was an HIV positive father and an HIV negative mother, and they wanted children, and so they wanted children by in vitro fertilization. So this Chinese scientist created twins that were edited with, yes?
Would you please give us your concluding statements?
Yes, this is it. Sorry. So this Chinese scientist created these twins that were missing this CCR5 protein that rendered them resistant to HIV. And Lulu and Nana, those twins were born in early December 2018. And so this was a huge scandal, because the consequence of this is we really don't know. Those children, of course, are going to be resistant to HIV, but what are the other consequences to them and their children after that, who they're going to pass on this modification in their DNA. So I hope this is it. I hope I was able to present you with, there we go. This is my last slide. So this is us as we were visiting in Mexico City about a year ago at Hospital Infantil de Mexico Federico Gomez. And this is our research institute at Children's Mercy in Kansas City. I hope I was able to give you a very quick flight over the genetics of epilepsy, and I will conclude because I think I went a little bit over, although I started late.